Today we're going to be discussing the technique for obtaining pelvis radiographs for submission to the Orthopedic Foundation of Animals, or OFA. So this is Reese. This is our patient that we're going to be doing the radiograph on today. She is a 7-month-old Shih Tzu mix, and as you can see, we have her under general anesthesia that's being maintained by isoflurane anesthetic gas. Given the fact that the positioning for this kind of x-ray can be kind of uncomfortable for the patient, it's best to use chemical restraint, both for their comfort and then obviously for ease of handling for the technician. So we have her in dorsal recumbency here in this V trough. It would be ideal if we just had the cranial part of her body in the trough to kind of decrease any sort of object film distance, but since she's kind of small, it would be sort of difficult to just have half of her body in the trough and then half on the table. But in any event, we'll just kind of compensate for that with our x-ray settings. So, like I said, we have her in the dorsal recumbency here, and it requires the pelvic extended limb view. So what we'll do here is, now that we have her in position, we can use our calipers to get our measurement, which is kind of difficult with the V trough, but essentially you want to measure at the thickest part of the pelvis. So I'll kind of slide these in here a little bit. So we've got about 8 centimeters. And so for that, we can go ahead and set our machine. So we've got a kVp of 75 and MAS of 5. Essentially, the best rule of thumb for these kinds of x-rays is that you want high contrast film, so that results in kind of having a little bit higher kVp and a little bit higher MAS as well. So how we're going to make sure that we have Reese's positioning appropriate is that I'm going to grasp both of her hind limbs, here kind of at the metatarsal region of both, and then you rotate the femurs inward to try to keep them parallel. And then the idea of doing it this way is that you make sure that both patellas are in the trochlear groove of both femurs, so it's on top of the hind limbs, and then you kind of extend and pull the femurs parallel to the table, so keeping them parallel to themselves and then also parallel to the x-ray table. And you want to kind of extend them down until you feel a little bit of resistance in the hip joint. So that, again, like I was saying before, this position can kind of be uncomfortable for the patient, so it's best to have them under chemical restraint to do this. So as far as for our collimation, which I'll move the table a little bit here, you can kind of see. Now, the main parts of the anatomy that you want to include in these kind of x-rays are obviously the entirety of the pelvis from the ilio wings. So you want to get about maybe the last 2 vertebrae of the lumbar spine, and then obviously as well as the pelvic bone. So we're going to kind of move our table a little bit. So I think we've got it there. And then obviously you want to include the entirety of both femurs, as well as the about a little bit distal to the stifle joint. So we want to make sure that we collimate to include those areas of anatomy, but then we don't want to, have too much scatter radiation, so we want to make sure that we collimate well there. So it's going to be close to that. Let's see if we can get it a little bit. So that's kind of the basic idea here. Obviously, we want to make sure we have all of our areas of anatomy, but not too much, to avoid any kind of scatter radiation to our personnel. And then we have our markers, which this is radiolucent, so we can actually put our markers beneath it, and they'll still show up within the x-ray field. So we have our R for our right, so we'll put that on the right lateral aspect of Reese's body. And then we have our VD as well to denote that this is a ventrodorsal view. So we've got her in position. We have, the sandbags that we have are kind of heavy, so I didn't want to put them over her chest, but we've got the glove up here that's basically keeping her hind limbs out of the way. We've got her straight in our trough. We've got our collimation ready, and so we'll go ahead and take our x-ray, and then we'll come back to see if there's any adjustments that we need to make to either our positioning or our technique to make sure that these are diagnostic enough to be sent to the OFA. Okay, so here's our x-ray, our OFA VD pelvis view, and as you can see, we have our femurs are parallel. Both of our patella are in the trochlear groove. We're collimated correctly. We've got the last couple of vertebrae of the lumbar spine. We have our entire pelvis, both femurs, and then just distal of the distal to the stifle joint. So we have pretty much everything that the OFA requires to see in these radiographic views. And also, you know, our technique is good. We have enough contrast, so we didn't really need to make any adjustments to our x-ray settings or anything like that. So I think we can feel fairly confident as far as sending these out for evaluation by the OFA. And essentially what they're going to be looking for is any evidence, at this point early evidence, of future canine hip dysplasia for this patient. They're basically going to be looking to see, you know, how the femoral heads, you know, how much conformity they have within the acetabulum of the pelvis, any kind of laxity or anything like that in the coxofemoral joint, and be able to make their recommendations and evaluations from there.